That's it. It's always fantastic when the AV works out of the gate.
There's a mic here if you want to talk about
That's probably, y'all can hear me back there, right? Yep. Okay, great. Well, good morning, everyone. Appreciate being invited here today to talk a little bit about the work we've been doing. As Justin mentioned, my day job is very different from the subject that we'll be talking about here today. The firm that I work with most days is a cybersecurity consulting firm. We do quite a bit of technology work, mostly for the U.S. government. But we founded this company about 2.5 years ago, working with Robert Murator, who many of you know. Robert, good morning. Appreciate you being here as well. So this project that we started was really came out of a problem space that I think many of you are already familiar with. So there are several ways to manage bone growth stimulation for especially patients who for some reason feel that there might be a risk of their bones not healing in a timely sort of way. The three technologies that have traditionally dominated that space, at least before, say, the early 2000s, were the pulsed electromagnetic field, combined magnetic field, and capacitive coupling technologies. These are all electromagnetic technologies that ever since the late 90s, Smith & Nephew, then Exogen, nowadays Bioventus, created a low-intensity pulsed ultrasound solution that used acoustic excitation to accomplish the same means. And when you look at the relative efficacy and we call it convenience of those four technologies, LIPUS really stands out as simply just a more patient-friendly and a much more effective technology than the other three. As opposed to being wired up to a device for an entire day or to have to use a device for up to 10 hours a day, LIPUS requires just a 20-minute-a-day treatment and has a success rate for non-union fractures in the mid-80 percentile range. Now, of course, even with that, it's difficult sometimes to get patients to use these devices. There was for quite a long time a feisty secondary market for the Exogen device, which in many ways they've shut down through some creative software tinkering on the device itself. But the actual demand for this device and the market space itself is really kind of interesting. The first thing is that, it turns out, and this is just for the United States, by the way, there are about 7 million bone fractures every year. That big blue circle is growing. People are more active now than they ever were. Extreme sports have taken off, and it's true that people are just breaking their bones at rates that we haven't really seen, I think, since perhaps the Middle Ages. The fresh fractures at risk, we call it. So those are the fractures that, for some reason, we believe aren't going to heal in a correct or a speedy sort of way. Those are patients that have typically some kind of vascular insufficiency, whether it's osteopenia, osteoporosis, some kind of metabolic bone disease like bone cancer, something along those lines. Even just smokers or patients of advanced surgical age. And of those 700,000 fresh fractures, about 10%, about half of those wind up becoming delayed and non-union fractures. So those are fractures defined as fractures that don't heal after the expected period, which is usually somewhere between 30 and 40 days, depending on the fracture. Now, of that total delayed and non-union market, which is the addressable FDA-approved market, we see that bone stim technologies, those four technologies from the previous page, are really accounting for about 17% of that entire market. So there's a combination of reasons for why that's true. One is just simple awareness. Not every single physician knows of the technology, although Exogen has done, I think, a great job of trying to get that word out over a period of decades. Second of all, it's a little bit expensive. Insurance doesn't always cover it. So for a device that retails for about $4,500 and winds up getting comped at somewhere around $2,200, it's still sometimes difficult to get through, especially some of the lower end insurance models. So the total addressable market winds up being really, in our view, that entire fresh fractures at risk circle, but really there's some FDA hurdles you need to get through and some reimbursement issues that a better priced device we feel would actually do quite well at. So having gone through all this alone, we see a total addressable market of about $700 million a year, just the USA alone. Now, excluding spine, which almost always uses some sort of metal fixation, whether it's wire or screws, and thus isn't very conducive to being treated with ultrasound. We see that market growing in actuality to about $400 million by the end of the decade. And it's growing at a rate of almost 7% per year. Today, after the last 20 years of work on biovenous exogens part, we see ultrasound having more than half of that market today. And it really is the only device in the United States that's been FDA approved for treatment here. So again, a very expensive device, really making a little bit of a fortune on a relatively low cost of goods sold. And there really, other than changing the casing and adding some software features, there really hasn't been any meaningful enhancement to this device since the mid-90s. So that all translated into what we saw as an interesting market opportunity. And based on some technology and research that we had and had been doing, we decided to try to make a go of it with a proof of concept study. So the proof of concept study itself was conducted last year between us and Thomas Jefferson University Hospital. Some of you might know Fleming Forsberg. He was our principal investigator at Thomas Jefferson. The study itself was mostly funded out of a new venture capital arm of Thomas Jefferson called Jefferson Innovations. So they put up about 80% of the capital to run through our in vivo animal study. The animal study blew us away. The results that we got were surprising even to us. We found that our device performed about 25% better than the market device, meaning specifically that we ended up with stronger bone and stiffer bone at the end of the study with a confidence level of at least 95%. That was surprising. The study itself was 17 rabbits. We induced bilateral fibular osteotomies, which is an easy study to get approved through the IACUC because it's just not a weight-bearing bone in a rabbit. Fibula actually terminates mid-leg, and so their bunnies are literally hopping around almost immediately after surgery. We treated the animals with our prototype device for about 20 minutes a day over a period of 18 days, and ultimately sent tissue samples to Mayo Clinic for DEXA analysis and torsional testing in their biomechanical lab. Again, the results were really remarkable and exciting to us, and ultimately allowed us to submit a provisional patent disclosure for our signal. And at the same time, we began gathering some very interesting data for fracture healing assessment. So that's just a concept that's already out in the space and being used with a couple of different techniques, but it's by no means state of the art, right? So we imagine that a fantastic discriminating feature of our device could be if we can actually say how well the fracture is healing as it's healing in real time. That would be of tremendous value to the patient. And I alluded earlier that patients don't always use these devices, right? They end up on the secondary market and without ever having been used, even after they've been prescribed, which we decided isn't easy to do because of the price. Why is that? Because the device gives really no feedback whatsoever to the patient, right? You put the little transducer on the leg or the arm, and you turn on the machine and a light goes on, but you don't feel anything, you don't really see anything, you have no indication that it's actually working. So it's some sort of feedback mechanism we've imagined would potentially dramatically increase actual usage and adoption, and perhaps also make it easier for the insurance companies to comp the device. I thought I would put up a slide that just showed the differences in the destructive testing between the exogen device that we used contralaterally for each rabbit. Right, we tested one paw with our device and the second with the exogen device, and compared the two within the same animal. And that pairwise testing allowed us to eliminate biological differences between the animals. And you can see, unfortunately, the way that the testing machine kicks out results, you can see that the scales are different, right? So the exogen device in this case gives you the torque in Newton centimeters up to 5. In our device, it's up to 9. So if you actually look at the slope of the line for the exogen device, and it might be a little hard to see that in the back there, it's a slope of 0.1 with a max torque of 4.9, let's call it 5. On our side, we ended up with a slope of 0.24 and a max torque of nearly 9, almost double. So the slope of that line, that red portion of the line, that's the bone stiffness, as it were. And the bone strength is the point where the bone actually snaps with the destructive torsional twist testing. And you can see that we achieved a max torque of almost double the exogen device, pointing to simply a stronger bone by a factor of 2 in this particular example after the same amount of treatment. That was just this one animal. Overall, we ended up with about a 25% increase in those two values. So armed with an exciting proof of concept study, our next step is to move on to a dosimetry study. We have really 3 core objectives of that study. One is to try to see, again, how well our bimodal signal does on bone fracture healing in another in vivo animal model. Second, to continue gathering data to develop and improve our bone fracture healing assessment algorithm. And then finally, to make sure that we do those tests under FDA guidance, following good clinical practices, and ultimately hope that we end up with a device exemption so we can move on to clinical trials. Now, in terms of the actual hypotheses of the study, in the proof of concept study, we were very specifically trying to test against the exogen device. So the null hypothesis that we were really trying to disprove was that the exogen device would do better than our multimodal signal. And in fact, again, showed that we disproved that hypothesis by with a nice confidence level. Slightly different approach for the dosimetry study. Here we're going to be testing contralaterally against the sham. And the specific hypothesis we're working to disprove is that the sham control ends up providing greater than or even equal healing to our multimodal approach. And again, we'll look for a p-value of 0.05 to reject that. Now, the statement of work itself, we're going to ramp up the size of the study to 48 rabbits. We have actually 3 slightly different variants of our signal that will divvy up amongst effectively 3 cohorts of 16 animals each, with a contralateral sham on each animal. We'll follow the same bilateral fibula osteotomy approach. We're going to up our treatment time just slightly to 23 days from 18 days. We found that in the proof of concept study that after 18 days, we were still very much in the middle of that soft callus phase where we really hadn't formed solid bone tissue yet. We want to get the healing, just advance it just a little bit more. And this is a little bit of an art and perhaps not a science. We're trying to get to the point where, obviously at a certain point, if we waited too long, both devices would end in the same place. Eventually, the animal would heal and be very difficult to tell any difference. And if you wait too early, you're also not going to see any difference because obviously if you test it on day 1, there's not going to be much of a change. So we're trying to find that sweet spot of how many days to treat. And we think that somewhere around 22, 23 days is the right number. Really the important part is to try to get to that sort of that sweet spot of comparison. We'll do the same exact approach that we followed in the proof of concept with X-rays, DEXA scans, ultrasound scans, and ultimately torsional testing. And again, continue to gather that fracture healing assessment data that I discussed. So in terms of milestones of the study, we have one entry milestone and two exit milestones. On the entry side, we're working on developing an engineering prototype device. In the initial proof of concept study, it was really a lab bench unit we were using for most of our testing. And in this dosimetry study, we want to have an actual prototype device. Not a production prototype, mind you, but a solid engineering prototype. And then in terms of exit criteria, we're certainly looking to validate the dosimetry, which in this case is which of the signal variants will produce the best results amongst the three cohorts. And then finally, finalize utility patents for both the signal and for the device that we're building. Which brings us to lessons learned. First of all, and the importance of building a strong team. We got incredibly lucky with our collaborators in the proof of concept study. Certainly, Thomas Jefferson and Mayo Clinic are world-class institutions, and we're fantastic partners. They both brought quite a bit to the study. On the Thomas Jefferson side, they brought a scientific rigor and just their clinical expertise in managing a study like this was excellent. We followed well, I suppose I could call it a double-blind study, although I'm not sure the rabbits would have told anyway. But it was where even the people doing the treatment weren't always sure, which animal was which. And finally, on the Mayo side, the equipment that they have in their biomechanical lab is just extraordinary. So they were able to ultimately do this testing in a very crisp and rigorous way. We followed I'd say a very detailed project management discipline. The number of moving parts of even a simple study like this are kind of extraordinary. And it's always tempting to try to think that you can just sort of wing things like this, but you absolutely can't. So really keeping detailed track of to-do items and weekly tag-ups and all that was incredibly helpful. We also, I think, put a little bit of money up front into getting the legal side of things squared away. So helpful tip for anybody contemplating a medical startup. Those costs can be a little bit more than you expect, but certainly when you're attempting to do business with a billion-dollar institution like Mayo Clinic and the rest, it's good to at least have a little bit of paperwork between you to make sure that interests are protected. The risk register is something that I certainly do for any project in my day job. And the idea here is a fascinating one. The idea is to imagine how your project is going to fail. Right? Really sit down, and this is the hard part. When you get a lot of bright people in a room and excited people, and we all love our projects and our technology, it's very tempting to focus on the success, and you're already counting your money, even in the early planning stages. However, it's incredibly important to ask yourself how your plans are going to go awry. Think about all the things that can take you down, and try to create a risk register of sorts, and try to inoculate yourself against those potential calamities. And that leads as really a subset, but I thought worth calling out, was the importance of building in redundancy at every single level. That's redundancy of personnel, redundancy of devices, redundancy of features within devices. The amount of commercial equipment failure that we enjoyed during this proof of concept was sort of remarkable. But luckily we had backups for our backups, and it all worked out. Even that one time that the power supply caught on fire, because apparently that's a thing. The statement of work. This is something that really we didn't do a great job of, but I think that we've definitely learned a lesson in that the statement of work has to be a living document. We really developed a very detailed statement of work, and we worked to follow it. And at various points along the way, we pivoted as we needed to, but it would have been crisper and clearer, I believe, especially when it comes to coordinating between the different institutions, if we had actually had more formal change request and update forums. We ultimately ended up on the same page, but there was just a little bit of friction and perhaps needless arm waving at certain times, where I think a more formal change request process would have really helped. And then finally, the funding never happens as quickly as you imagine it's going to, and I'm sure I'm preaching to the choir here. It takes time to put paperwork in place. Even after you have a deal, actually getting the checks cut can sometimes be a little bit painful. But it all worked out, at least so far, and we're excited to move on. So with that, I will say thank you, and certainly throw it open to questions if there are any. Sir.
I was sitting here trying to remember, did you go to the FDA and talk to them about a filing so that you could use your animal study in your FDA filing? You know, I can't remember the name of the pre-sub. Did you do a pre-sub?
Yeah, no, we're planning the pre-sub meeting in advance of our dosimetry study. So this was very specifically not a phase 1 study. This was a proof of concept. This was, and the FDA is very crisp on when they will allow you to use your results and when they won't. And the plan here was to ultimately do the study, write a paper about the study, and then Thomas Jefferson is submitting papers. They actually gave a paper on this at AIUM last week, and they have papers submitted to RSNA, and they're intending to publish an article on the study as well. And it turns out that you're able to reference published studies, and you can enjoy the results that you achieve from the published study as a way to formulate your phase 1 study with the FDA. But you're absolutely right. They definitely want you to get with them. If you're now doing like what you call a phase 1 study and you want to then move towards an IDE, it's critical to get the pre-sub in place. And we're working on that right now. Sir.
In your graphs of the torsional tests, there was a difference between the two for the rotation angle.
Yeah.
Can you comment upon that?
Robert.
Right. So this is an automated machine, and it just basically, goes until failure.
Yep.
Right. So when that failure happened in a shorter turn, then that was the end of that particular run.
Okay, and that happened at a smaller angle for the ASA in comparison to the exogen. So is there a physiological significance in
Could be
that?
stiffness, right? One is stiff, could be stiffer, that's why the rate may be.
Yeah, okay.
Right. So if it's
So it's
stiffer,
not
it could snap sooner. If
Yeah.
there's more cartilage, it can just keep turning without snapping cleanly.
Yeah.
Why did you use torsion as opposed to tension or something like that? That would have been.
No, that's exactly the right question. So this is one of the standards in the field, and it goes back to a study that Pilla did, and the Exogen device was based on Pilla's study, so we were trying to emulate that as best that we could to get a good apples-to-apples comparison.
What he said.
I have a question on the energy density. This may be a question for the model.
I'm certain it is, without me though.
And I know it may be proprietary, but in what general areas, like how many watts per centimeter squared were you looking at? You said there are 3 variations in the signal. Can you comment on the differential? How you differentiate that, and what was the multimodality effect?
Right. So so this was around a megahertz or so, in that range, and it was about 50 milliwatts per centimeter squared at the bone, so the difference in this signal from the Exogen signal has to do with inducing more of a shear wave content into it, right, which would give you a different travel along the bone and maybe penetrate the fracture better.
You know, it's actually very interesting that the actual biological mechanisms at play here are not perfectly known. We've made a lot of progress in the last 20 years in understanding how it happens. There's something going on with integrin response and messenger RNA and what have you, but to the best that we can find, it's really about stimulating blood flow to the fracture site. And really, that's what all of these technologies have in common, right? The ability to actually increase blood flow and this multimodal content that Robert's describing seems to do a better job of doing just that. So if you imagine the fracture is just like an acoustic channel, you know, the goal is to try to get that ultrasound signal kind of right through that channel and cause maximum excitation. So
Right. So to amplify that, right, it's not necessarily like a heating effect to open up the capillaries. We're really talking about angiogenesis here, right? Stimulating the growth of new blood vessels so that the bone could then follow. Bone growth could follow from that.
Gentleman in the back.
Can this be used in hairline and stress fractures as well? Because that'd be a whole different marketplace than like compound fracture.
I don't see why not.
Okay.
Yeah, I imagine that's the exciting part about this technology is that really any vascularity is so incredibly important for the healing process, period. This has a place in wound healing, has a place in really, especially imagine patients with persistent wounds from infection and what have you, or bed sores, and things of that nature. There's some really exciting markets this could open up. The other thing that the multimodal signal may do, to be tested, is that it might make ultrasound ultimately suitable for spinal fusion healing, which today, again, isn't really part of that addressable market because of the Kirshner wire and the metal fixation plates and the rest. Sorry, in the back.
So in terms of your testing, would you run that for a 24-hour period, or would you run for any appetite comparison?
The estrogen device, like is a 20-minute per day treatment. So both devices were run contralaterally on each rabbit for 20 minutes for each of the treatment days. Sir.
You mentioned one of the reasons for which some of the devices were not being used was the lack of feedback on the progress.
Yeah, well, it's a hypothesis. We're trying to account for all of the brand new devices we see on eBay.
So does that confirm that you were planning something along those lines with your device that you need some feedback about the healing stage of the fracture?
Yeah, and that was perhaps I moved past it too quickly, this fracture healing assessment concept that we started gathering data for in our proof of concept study and plan to expand on significantly in our dosimetry study. We've engaged a research team at the Mayo Clinic that's done quite a bit of work in the elastography area, and our intent is to try to put together an algorithm that encompasses aspects of elastography and other aspects of sound measurement that we believe would ultimately end up with I think a very accurate picture of how well a fracture is healing over time. And what's exciting about that, and this is where we get into a dicey area with the FDA, is that with enough data, we could conceptually get into a machine learning assisted healing approach, wherein the device itself starts learning what signal variants and what placement and what other features, power levels are the patient is responding to best, and actually varies the device dynamically to maximize healing as the machine learning goal. Now, of course, the FDA is terrified of machine learning for just that reason, right? They don't really want their device modified on the fly to do anything. So we have a bit of an uphill battle there, but the science is interesting. Sir?
How did you immobilize the rabbits? Like, I'm just puzzled by how do you prevent the rabbits from re-injuring the bone? How do you know whether they, the rabbits and when they re-break the bone while you're trying to, and then that kind of clouds your data? Did you see any of that, or are they just completely immobilized during this 20 days?
You know, it's funny, we in the lead up to the proof of concept, we came up with all sorts of ideas for how we would immobilize the rabbits. We had these, we contemplated slings and, you know, swaddling and all sorts of, notions. And ultimately, Thomas Jefferson came up with a fantastic solution. They just administered a very, very light sedative, which again is just for the 20 minutes.
20 minutes.
Just for the 20 minutes. No, we didn't. This is not. This is not like Saw or anything. We just put them to sleep, and they're not even to sleep. They're a little just groggy and lethargic for the 20 minutes that we were treating them. Cook had no problem with doing that. It's a very light sedative. And to the other point, the fibula is not a weight-bearing bone in a rabbit, and they're literally hopping around happily almost immediately after surgery. So it's a good model to use for this purpose. Are we doing on time?
Yeah, 2 more questions.
2 more questions. Any other questions? Maybe 0 more questions. See no more hands. Well, the music stops, the show's over. Thank you very much, everybody.